Well, welcome everybody to our annual Bucksbaum Symposium. I want to welcome people who are here in the room, welcome people who are in the room next door as well, and welcome all of you on Zoom today to our symposium. It's an exciting time of the year where we honor our Bucksbaum board with members who are here and really talk about the great work that the Bucksbaum Institute has done for the course of the year. And the highlight is really this keynote lecture, and it's my pleasure to introduce to you our master clinician, Dr. Maru Ranella. Dr. Ranella is a transplant hepatologist with over 20 years experience in treating patients with complex liver disease. She's an expert in non-alcoholic fatty liver disease, or NAFLD, which is one of the most common causes of liver disease in the United States, and unfortunately can progress to cirrhosis, liver failure, and death in many of our patients. As part of our metabolic and fatty liver disease program, Dr. Ranella provides comprehensive liver disease assessment and treatment, including nutritional intervention, use of medications, endoscopy, clinical trials to deliver the most advanced treatment. As part of her approach to care for liver disease patients, Dr. Ranella is passionate about using research to advance medicine. She's investigated a broad range of topics within NAFLD and has published well over nearly 150 peer-reviewed articles in many prestigious journals in this area. Along with her clinical expertise and research accolades, Dr. Ranella is also dedicated to teaching residents and fellows, providing guidance and mentorship throughout their medical careers. At the University of Chicago, she's currently a professor of medicine, director of the Metabolic and Fatty Liver Disease Program. We were thrilled to name Dr. Ranella the 2022 Bucksbaum Institute Master Clinician. She's going to give us a talk today, and I will mention anybody who is on Zoom, please mute yourself for our talk today. The talk is a long and bumpy road from NAFLD to MASLD. Did I pronounce that right? To improve the care of patients with steatotic liver disease. Dr. Ranella.
Thank you, Matt, and thank you to the Bucksbaum Institute for the honor and for the invitation to speak. And so what I'll be doing is taking you through what I've been doing for the last 3 years, which I hope is of interest. So these are my disclosures. Like I said, we're going to talk a little bit about the burden of disease, and we're going to talk about the new nomenclature for NAFLD, now MASLD. So I think an important place to start is just understanding the burden of disease. So this disease, MASLD or NAFLD, is about 1 in 3 Americans right now. Now, a smaller group of those patients, which would be those with the yellow and red livers, or those with more advanced liver disease and cirrhosis. And unfortunately, predictions for 2030 suggest that there's going to be not just a significant increase in the overall prevalence, but actually in the severity of disease. So we're going to have 168% increase in hepatic decompensation, 178 in liver-related death, and specifically there's a very significant increase in hepatocellular carcinoma. So one of the biggest problems is that this is a very asymptomatic disease for the most part, and liver chemistries can be totally normal. So of course, it makes it very difficult to diagnose. So this is actually the wrong reference. It's an Australian reference, similar sort of vibe, but basically it's your data from the United States. And you can see that not many people actually code NAFLD and NASH. But if you look at patients who have implied disease based on their risk factors, you can see that the burden is significant and it's underappreciated. And most of these patients reside in the primary care setting. So this is, of course, the fastest growing indication for liver transplantation. And while it's sort of increasing, it looks like on farm alcohol, look at the full change over the last 10 years, it's really dramatic. There's been a 5-fold increase in transplants needed for NASH over about a 10-year period. Yeah. Yes. So I'm going to go through that in a little bit. But so NASH, or is steatohepatitis. So it's histologically defined traditionally, but with non-invasive testing, we are moving towards non-invasive diagnosis. It's very hard to diagnose with biopsy and not reasonable. So I think this low awareness that I alluded to leads to late presentations. So anecdotally, I'll tell you that nearly every single week I see a patient presenting with decompensated cirrhosis who've been followed for 20 years by their doctor and told that they have just getting awareness and they didn't even worry about it. So on the left-hand side, you can see the only large prospective study. This is an NIH-funded study from the National RN. You can see that when you have F3, which is pre-cirrhosis, or F4, which is cirrhosis, you have a very significant increase in hepatic compensation, but it takes a little while to occur. So on the right, this is data from a claims database of 2 million people who are insured. And you can see that most are getting diagnosed at advanced stage, and the time to first occurrence very much faster than we would expect, which means that they're being diagnosed in late stage, and we need to stop that. So there are numerous barriers to awareness, and I spoke to the minimal side effects, minimal minimization of consequences by providers, low prevalence of understanding of how you risk stratify. How do you take 100 million people and then find out who actually is at risk, right? Lack of clearly defined therapy, that's going to change in the next 6 months, I think. And there's stigma associated with the terminology, which can be, linked to alcohol, which is, stigmatizing for some, but also disparaging to those with alcohol-related liver disease. The emphasis that it's not that, right? And then fatty, of course, is also a stigmatizing term. So I wanted to take a step back and talk a little bit about the impact of nomenclature, because it can really be very impactful. And in fact, this can change the way societies perceive the disease, the development of therapies and understanding. So the plague is a great example, right? In the sense that decimated about 25% of Europe's population, was identified all over, but really not specifically characterized until efforts in England and in Italy sought to systematically classify, identify, and describe patients. And that then led to a better understanding of who had the disease and how it was transmitted, and ability to identify people early and isolate to limit the spread of disease. Tuberculosis has also gone by many names. It wasn't until the mid 1800s that the term was coined, tuberculosis, but consumption was still used. So despite having a new nomenclature, consumption was still used until the beginning of the the end of the 1800s. Rubella, again, has had about 15 different names and until one stuck in 1940. And then there's perhaps no better example than with the AIDS epidemic in the 80s. So this is an example of how badly you can stigmatize a population. So believe it or not, I actually didn't believe this, that this is true, but the term GRID was used, albeit briefly in the United States, only for about a little under a year. This obviously was terribly stigmatizing and marginalizing for an important people. And then lastly, COVID. So we're all very aware of what happened when the term China virus or Wuhan virus was linked. It created significant backlash against Asian people, and these are things that history can teach us. So nomenclature really needs to touch on various things. So it needs to be a use of stigma. It needs to help in understanding the disease. It needs to be accurate, precise, have clear defining characteristics. It cannot marginalize for individuals, and it needs to be understood and made aware across all stakeholders, and there has to be a linked clinical care pathway. So this is not new for this disease. So the term NASH was coined in 1980 by Jürgen Ludwig, who's a pathologist at the Mayo Clinic. And he identified a group of patients that had steatohepatitis, just like you see with alcohol, but they didn't drink at all. And so he coined those non-alcohol steatohepatitis. And then in 1999, 20 years later, Marioni described the full spectrum of disease, which we then knew as NASH, non-alcoholic disease. From there, I guess I'm almost have to admit at that 2002 conference, but we discussed other names and nobody could really pin it down. We didn't really know enough about the underlying pathophysiology, so there we sat for 20 years again. So in 2020, a group from Australia, but many of us were included in the international consensus panel in quotes, and I'll tell you why in a minute, because they really brought up some reasonable things. Like they identified a name referred to as metabolic dysfunction associated with fatty liver disease because it called the disease what it was instead of what it wasn't. It removed stigma of alcohol from the name. It provided diagnostic criteria, and it recognized the close relationship with metabolic disorders. But the problem is that they also changed the definition significantly. They eliminated steatohepatitis, and that is the most important driving force for the development of fibrosis. And they very liberally allowed alcohol, so there was no upper ceiling. So you could drink as much alcohol as you wanted, and you'd still be called MAPL. So this has obvious implications on natural history data, the way we might respond to therapeutics, the biomarker space, et cetera. So a group of us had significant concern over all of those issues, but also the concern over the validity of the process. Having been supposedly part of the international consensus panel in the Delphi process, now that I know what a Delphi process is, we did not do that. That was not what happened at all. So this was a big issue that I really felt was an existential crisis for the field. So one of the things we spent a lot of time on is, well, what is consensus, right? How do you define it? Is it a majority? Is it supermajority? Is it unanimity? You know, what is it, right? This is a very contentious issue among investigators in the field. And I like to refer to this particular example. So United Nations 1950 Security Council, which requires 100% of the votes or unanimous vote to pass a resolution. Soviet Union was missing, and the decision was made to enter the Korean War, purposely or not purposely, but they haven't missed a vote since then. So I think when you have a very difficult issue, you really can't expect a high degree of agreement, because to me that tells you that you probably didn't have all the stakeholders at the table, and you probably didn't actually discuss in detail, because things can be quite contentious. So the other thing that happened in this process is there was a lot of politicization that occurred, and this again, we all know this with the mask mandates that occurred. You know, we have good data to show that there was a clear correlation between using masks and preventing disease, improving outcomes, but along party lines, we got lack thereof or mask mandates, which makes no sense. And then lastly, you can do everything you want, but if policy doesn't move, you're not going to have any success. So again, this is a perfect example. 1964, 40% of the US population smoked. In fact, the Reynolds advertised in JAMA, sponsored the American Medical Association meeting. Right now, we're like, that's crazy, right? But that's actually true. Until in 1964, the Surgeon General said, you know what, this causes lung cancer, and it might cause other diseases. And then from there ensued multiple policy decisions that then led to significant reduction in smoking in our country. So as I said, we embarked on a Delphi process, and one of the critical aspects of it is it has to be informed by subject matter experts. It needs to be conducted using rigorous methodology, meaning specifically methodologists that are expert in this process. There has to be complete anonymity of voting and reporting of results, and it has to be transparent. Survey rounds need to be combined with in-person discussion. Once the survey rounds are complete, or certain aspects of it, there needs to be discussion over things that did not reach consensus. And this is important because this is how we assure that as many voices are heard as possible. This is a weird duplicate, so. Okay, so I'm not going to bore you with the whole process. It was long, but we basically had 264 nominees from the largest liver associations in the world, and we represented representation from 56 countries. This is our steering committee, was a very highly expert group in the field, and there are also patients mixed in here as well. So we sought to answer these 5 questions primarily, and that was whether there was an issue with the current nomenclature and if we could actually address it. What's the importance of steatohepatitis in disease definition and endpoints? How are we going to manage the role of alcohol, because it's very pervasive? And how might a name change impact disease awareness, clinical trials, regulatory approval pathways? Because as I said, we're very near an approved drug for this. And then can we identify a new name that's going to help hone down on what's currently a very heterogeneous disease, and then hopefully be able to incorporate future advances. So those were kind of the basic things that from which we derived our statements. So here, I'm not going to read through all these, but in short, it was a very long process. We considered about almost 3,000 comments in this process, reading every single one and trying to modify statements accordingly. Our response rates to the surveys are actually quite high, around 85%. We did 2 in-person meetings, one in July in Chicago last year, we had a professional facilitator. It was extremely productive meeting. But the first meeting I've been to actually where people didn't have their computers out or looked at their phones. It's remarkable. And then again, another one at the liver meeting in Washington, DC. So what we ended with, and just from a conceptual standpoint, metabolic dysfunction associated with steatotic liver disease is what we refer to as NAFL, okay? And then within that, steatohepatitis are patients who are more likely to progress to cirrhosis. And so those are the focus of treatment intervention. But importantly, we added an overarching term. Why? Because there are many other things that cause steatosis in the liver. And there's this black box of nobody really ever talks about the patient who meets criteria for MASL, but also breaks a little bit more or a lot more than they should, depending on their metabolic risk. And so we created a new category called MET-ALD, and this is actually already being studied. I was very happy the first day I was invited to go to an ad board for MET-ALD. I was like, yes, that's great. So it's a group that really I think needs to be studied, and very happy that there's been that. And then, of course, alcohol-associated liver disease and many other causes of disease. And the purpose of the overarching term is to be able to incorporate new science. So this was published in 3 journals. We've had at least 75 societies endorse. And the definition, again, this was very contentious. And so one of the most important things that we had on our minds, we needed to provide an affirmative set of criteria, but we needed to err on the side of inclusivity. Because what we didn't want to do is define a different population, then would have different natural history, and then we would lose 20 years of data that we've accumulated. So we wanted we wanted to be simple and easily available metrics, so that it would be easy whether you're at the University of Chicago or in a rural setting. And also we wanted to make sure we aligned with cardiometabolic criteria that were fairly well established. Metabolic syndrome, of course, is extremely hotly debated, and one of the biggest arguments and discussions we had was over the term metabolic, what it even meant, should we use it or not, and we ended up with a supermajority to include it. And then we took a subcommittee of internal and external people, and then vetted it with pediatric that adopted pediatric population. So this is part of the ASLD, it has multiple tools, videos, presentations that we've made to sort of help facilitate the transition. Metabolic risk, and it's very, very broad. Again, on purpose, steatosis in the liver, and any one of those at least just gets you a thought and secondary testing, depending on the FIB-4 score, which I'm happy to talk about if you wish. So it's nice to see that over the last couple of months, in fact, it isn't even published in final form yet. It will be published in the December issue, I think, of Hepatology, Journal of Hepatology and Annals of Hepatology. But we already are seeing a significant increase in manuscripts using this terminology. So alcohol has also been another point of significant debate. Alcohol is very common in many countries and cultures. And we need to balance sort of reality without impacting natural history data. So one of the issues with MAFL was that they really didn't limit alcohol, but that is a problem because it significantly alters natural history and responsive therapeutics. So as I said, this is a very common reason for exclusion. So I was very happy to see, to remember that Hippocrates had commentary, very wise person, right? So wine is a thing wonderfully appropriate to man if in health is a disease, it's administered with appropriate and just measure according to the individual constitution. Well, that's absolutely true because we know there's a synergistic effect between weight, other cardiometabolic risk factors, and alcohol consumption. And the first glass of wine is for health. Second is for gaiety, the third is for good sleep, and everything further is a danger. And I would say that is absolutely true. But occasionally can be fun. Okay, so with respect to the impact of alcohol and cardiometabolic risk factors. There's no doubt that there is at least additive, but very likely synergistic effect, particularly in those who have central obesity. Here you can see at the bottom, again, it's very nebulous what you even call moderate risk drinking. This is actually in evolution right now. Different bodies recommend different quantities, but in any case, you get the point that the more you drink, if you have metabolic syndrome, you are going to have worse outcomes. And here on the right, you can see a very nice graphic basically demonstrating that even after 10 grams a day, you're starting to see an increase in morbidity, especially in people who have excess or in central obesity. So there have also now been several publications looking at MET-ALD and the different subcategories to see if we can differentiate different sort of outcomes, at least epidemiologically. This is a paper that just started to discuss really that this is a spectrum of disease that we all see, and we need to think about it and how we recommend therapy. So the alcohol community was actually quite upset with us because they say, well, anything over a drink a day is alcohol-related liver disease. The problem, though, is that they don't address the diabetes, the obesity, and all those other things that they do need to address. So we need to address both things. We need to take good alcohol histories every time, and we need to address cardiometabolic risk. So this is another study. This is from NHANES, just demonstrating that there is a differential risk in those with MET-ALD compared to pure MASLD, and certainly those with ALD and metabolic dysfunction, which is a large proportion of people with alcohol-related liver disease. So we've had very nice broad implementation across cultures. I was recently in South America. It was being used extensively in Prague just last week. It's being used extensively. And on the ASLD side, we've translated it into French and Spanish, and Portuguese is in process. Mandarin, Arabic are also in process. So we should have the website translated and all of the supporting documents into those languages as well. Again, EASL, which is the European Liver Society, they had their first SLD summit a couple of weeks ago. So stigma. This was another debated issue because in some cultures, there is no stigma associated with fatty. The translation, like in Spanish, hígado graso, is like, it's not really a stigmatizing term per se, right? So stigma is going to vary from one individual to the next. It's going to vary within cultures and within languages or between languages. But we decided that instead of using fatty liver disease as our umbrella term, we decided that it would be prudent to avoid stigma if we could. And the rate of perceived stigma in our study was 66% felt that the term fatty was stigmatizing and was an impediment to talking about the disease openly. There are several papers two of which are going to be presented in about a month at the ASLD, and another paper that's in press. So as far as impact on patients, I think there are several advantages. We use non-stigmatizing language. We allow for more seamless discussion of the root cause other than it's not alcohol. Well, then what is it, right? So then you really do need, I'm a believer in explaining to the patient so that they understand and can make informed decisions with you. And so I think this does help facilitate that. And again, it offers a diagnostic category for a group of patients that was really, I think, understudied. The disadvantages are that this is medicalization of the lexicon, right? So, and there's less familiarity with these terms. I still tell patients that they have fat in their liver, but I focus much more on the why and the sort of the cardiometabolic risk associated and how you might mitigate that, which is really managing cardiometabolic risk. So as far as practical application, this is, of course, much harder. So it's easier to reach people in your own society and then a little bit harder to reach people outside of your own society, but reaching patients is really where we need a very strong grassroots effort. So we have several partnerships with patient advocacy organizations that have been instrumental in helping us understand how to have this conversation. Webinars and again, little by little, I think we're making some progress. So we recommend this optimal care model, which is patients at the center. We want this multidisciplinary care, but really, to be honest, it's very hard to really do that. Most places do not have a multidisciplinary center like we do, actually. So we need to remember that most of our patients are sitting in primary care and endocrinology, and that's where we need to reach them. So this publication, there was a co-publication with ACE, the American Association of Clinical Endo, was, I think, a very important step in that regard, because there, we showed the risk stratification process to a primary care and endocrine audience. So as far as implementation and awareness, we really are working very hard at that. We do still have some things that we need to do, including interface with ABIM. With respect to publications, I think those are going quite well, and use and practice, that will take time. So this is not a problem of just the United States, right? This is a disease with a global prevalence of 30% also. Some of the highest prevalence is actually Middle East, South America. And so in part of an effort to elevate awareness of it, when we did this conference, we didn't have the new nomenclature, but to elevate fatty liver disease, there is no country in the world that has a plan, like an action plan for this disease. It's not even listed as a non-communicable disease by WHO. And so this was really meant to put our heads together, and these were endocrinologists, primary care, hepatologists, and epidemiologists coming together. And it was a really cool 3-day meeting, isolated. Maybe when you're isolated somewhere, you can't go anywhere, it's really a good way to get stuff done. But it's we came up with some action priorities, and it's again, I think that it's got good momentum. These are pretty basic recommendations. These are some of the things that we highlighted that need to be focused on. So basically everything, okay, from treatment of the patient in your office to policies need to be sort of impacted. And so I think that we're starting to make a little bit of movement. So as I mentioned, on a hepatology side, I think we're putting in a lot of energy into making this go through and be implemented. We do need to continue to interface with endocrine, cardiology, and primary care. And then, as I said, ABIM. Stakeholder meetings that are very important in this process are also, of course, the FDA, the CDC, WHO, who we have met with, and pharma. So effective implementation, as I showed you in the 1964 Surgeon General commentaries, that you really do need regulators and pharma, but also billing and coding ultimately needs to change. So this is a screenshot I took, and I asked his permission. So a screenshot I took at a meeting we held with the FDA about a month ago now. And I was very pleased to see that this is how we started the meeting. These are equivalent terms, and this is how we're going to move forward. So this is, I think, something that we've made some good progress on. This was, I think, a very important event. This was an event held during the World Health Assembly. It was a side event. I'd never done this before, so it was kind of interesting. We invited ministers of health from various high prevalence areas, and they came to speak. And then Slim Sama, who is the unit head of NCD management. So at the end of the day, we really need to be recognized there, and we need to change ICD coding, and that's something that we are working towards. So I guess to summarize, so this, I feel like the Gartner curve can really be applied to so many different things in life, but because if you would have come to me about 2 years ago, I would have been like down here, okay? And it was tough. It was really hard, actually, to be honest. But I really think that we're finally making some headway, and I really look forward to this being kind of behind us and just moving forward with making lives better for our patients. And I'm going to close with something that has been near and dear to my heart for many years. Actually, this concept we thought about 5 years ago. This is a project that I've been working on with Michael Charlton. And the point of this is to reach all those patients that are not even aware that they have disease. And then through this, it's primarily, education, but also providing linkage to care and risk stratification. So if you're a patient and happen to know your liver enzymes, then great. This will then tell you where you are in risk, and then it gives you a printout, and then you can give it to your provider. We have the same this is actually provided for patients as well. And if you don't have ALT, AST, you can use other meters to sort of approximate your risk, basically just elevating, this is being beta tested, it's out, so you can look it up, but it's in growth, right? We're developing it right now. I'm happy it's finally live. So with that, I'd really like to acknowledge the Bucksbaum family and thank you very much, because it's been, I think you've done amazing things actually for patient care. You've had a huge impact. Joni, of course, who's amazing, Mark Siegler, and then the Bucksbaum Institute faculty. I admire this president and I'm very pleased and honored to join. And Phil Newsome, who was my partner on the European side of this project, and I've got awards of the biggest ice associations who really helped us. Thank you.
For questions, both from the audience and if there's questions on Zoom, I think Dr. Sifu is monitoring Zoom as well. Questions on Zoom about this. And so let me start. I find it fascinating, this idea about changing nomenclature, and yet it's amazing how different words become so ingrained into our minds. How many people still use Twitter? Doesn't exist anymore, right? X or whatever it is. And how many people still go on Facebook? That doesn't exist anymore, but we still call it that. How do you see that we can get even down to the patient level? What are things that we can do with our patients to let them know that it's not fatty liver disease anymore? That's what they tell us they have. And what are some thoughts you have about how we can change the universal mind?
Wow, no, that's going to be hard, right? Because we get so used to things that it's hard for even me. It's difficult for me, and if it's difficult for me, then I can only imagine for other people. So I don't not tell people that they have fat in the liver. They do, and I can easily understand why. But what I try to focus more on is that this is what we have, and this is how we got there. So you have, whether I tell them, depending on the level of sophistication, medical sophistication of the patient, whether it's dysfunctional, metabolic response to, food or to calories, or and then focus on how you make the disease better, which is you basically reduce the cardiometabolic risk factors, instead of just saying, well, it's not this, because then people are always left asking, well, then what is it, right? And so I don't go through the whole acronym. I usually just say it's called MASL, And just like we don't know what BMW stands for anymore, we don't know what M&M stands for anymore, or a PDF, right? So I'm hoping that that will at least allow them to say, this is what I have. It's because I have deranged cardiometabolic response. So, but we'll see.
That was a great talk, Mary. Thank you. So when we exclude alcohol and we do SLD, if I got the nomenclature right, what are the main diseases percentage-wise that underlie or are associated with that condition? I mean, I have a view of it, but you're the experts.
So of the overlap of alcohol.
No, leave aside alcohol.
Yeah.
What are the other disorders that contribute to this condition?
Yeah, so very small. So we're referring to then celiac disease, Wilson disease, hypobeta-lipoproteinemia. Those are lysosomal acid lipase deficiency, drug-induced causes, and they're very small, right? So most people are going to fall into the MASL, MET-ALD, or ALD category, vast majority.
I guess what I'm getting at, what role does diabetes, obesity, and all that play rather than these rare diseases?
Yeah, so diabetes is highly prevalent. So about 75% of people who have clinically important MASH, steatohepatitis, will have diabetes. On the flip side, in a diabetes clinic, particularly, maybe perhaps a little bit less so in African Americans, but certainly in general, the prevalence is closer to 75%, and advanced disease is about 50%. So what you see in diabetes is an enrichment in advanced liver disease. More so than the overall prevalence of disease. So those are the patients that are likely to do poorly.
And obesity.
And obesity is also highly prevalent. So that would be probably the number one risk factors, and not just obesity is defined by BMI, but really central obesity. That's really where you see, of course, people who are Pacific Islanders or in Asia, where you have generally lean but centrally obese. That it's really all about central obesity and the propensity to put fat in your visceral adipose tissue compartment.
Cohen.
This historic context, I trained at the Boston City Hospital in the 1960s. We saw nothing but alcohol. So we thought.
Yeah.
So would you surmise that what we were dealing with at that time was this complex combination of alcoholism and other forms of steroid?
Yeah, yes, I'm sure that's true. I'm sure that's true. And I think that what the tendency was is that you'd see the histological lesion and even if the patient said they didn't drink, there's sort of like eye rolling. And there was really a major campaign actually against Ludwig. He couldn't even publish that paper. He ended up publishing in Mayo Clinic Proceedings. I mean, so that was a problem. So I think there was such a low recognition. And then also, I think since the 1970s, we've seen a steady increase in obesity. And COVID, of course, through the roof, obesity and alcohol intake. So I think it's more and more of a problem now than it was earlier on.
Seems that I'm sorry, go ahead.
Super interesting. So in my field of psychiatry, an area I work, personality disorder, our field has really struggled with the stigma and that kind of quote disease category. So we could use some of this. Were there example disorders that you took where there was a successful move towards a less stigmatizing nomenclature? Or was this like were you just sort of making it up or inventing it as you went?
Yes, so I'll answer the, I guess, second part of your question first. So yes, in liver disease, there is an example. So PBC, which retained the same acronym, which makes it easy, you would think. So what happened is primary biliary cirrhosis, which was a very stigmatizing term, and most people with PBC don't have cirrhosis, right? To primary biliary cholangitis, which is actually what it is. Even that was hard, okay? But it was achieved, and now most people say primary biliary cholangitis. With respect to why we did this, so it was really, and what I try to explain to people who are diehard NAFLD people is that what people don't understand is that there was no option to keep NAFLD. There was so much momentum with the NAFLD group. In fact, they had Twitter campaigns that are literally paying people to tweet, this, to, if you publish, they would pay. I mean, it's crazy. It's actually absolutely crazy. So there was going to be no option, right? They already had about 1,000 publications. And I literally had to convince one by one countries in Europe, countries in South America, Central America to get off of the NAFLD train. Why? Because of the obvious reasons we discussed. So we never would have been able to keep NAFLD. So just for perspective. And where we ended really is just a demonstration of the very significant disparity. I actually put the guy who started NAFLD and was propagating it and actually put him on my steering committee. So I was like, you know what? I want to vomit, but I'm gonna put him on there because I think it was the right thing to do, right? I mean, you really want to hear from everybody, and I think in the end it gave us an honest, reliable process. So it is a funny name, yeah, it is. But I think you just have to get used to it.
I just want to make a comment, stepping back from this context, to how I feel like you are doing academic medicine at its best, and let me explain why. We're here to advance science and innovative clinical ideas and take unbelievable care of patients, train people, and engage with our community, and then lead throughout the world. And I rarely am at a talk where I see all of those things hitting all at once. We talked about population level issues, we talked about international issues, we talked about cultural issues, we talked about scientific issues, we talked about how naming language, which we're starting to recognize, say around cancer, can be very stigmatizing, certainly, and in psychiatry, as a psychiatrist, right? But so societal implications. So you just kind of work through all of the things, and then by building this group, you're leading and changing policy and approaches throughout the world. So I just want to say, Mark, you have good taste, good job in choosing her, but also I think you're an incredible role model for demonstrating how if you get all of those at once, you can actually make transformational change. So good job. Thank you.
Right.
Recognizing that sort of billing sort of drives a lot of documentation and how things are sort of put in the medical record. And I think you said that there's not even an ICD code related to that.
You don't even use the ones for
or this.
NAF.
So how do that in that sort of diagram where it gets down to the clinicians,
Right.
it seems like a significant impediment might be that if we're unable to sort of, if it's a condition that doesn't readily show up, or we get a coding query because we're using a newer term and it's not billable. Is that the case here when you use that term, or how what
Yeah,
work is
so-
being done?
So I think in an ideal world where we wouldn't have had, pressure and had to be able to fight against something that was going to be not overcomable, we would have, it would have taken years and years and years to do this, but finally get to the point where now we're incorporated in ICD-12 and we have, CMS is completely on board. I mean, but the problem is we didn't have the benefit of that. So what I think it's going to be a little bit difficult, I think, at the beginning, but we are working very hard to do that. It's possible we may still be able to get something into ICD-11, but we're again working hard on multiple levels to try and make that happen. The only place where we really haven't made any headway is in CMS. I mean, we've tried, we meaning people that are much more powerful than me, like much more, have really had a hard time. So if anybody knows anybody at CMS, we really need, we need their ear on this. But nobody in government knows, weirdly, FDA doesn't know, CDC doesn't know, NIH doesn't know. So anybody know anybody? And
But so if you use this term in your documentation, can you go for it? I mean,
yeah, so what I would do for now is I would do / I would use both, and I would say, and again, it's just because it's going to take time for us to be accustomed to the new nomenclature. The billing issue is, your point is very well taken. We had a discussion with Tim Morgan from the VA a couple of nights ago, specifically talking about that and whether it was going to be, better to just in this transition period just use, / so that from a billing perspective it isn't.
On a side note, it's amazing to see you here after, training with you. And this amazing, I agree with Laura, this, really incredible talk on something that I actually didn't know much about. And so I was thinking about your multidisciplinary slide model with primary care and, hepatology and, the patient at the center. And, in my world, a lot of people ask me, how are we going to use primary care physicians and what are the workforce shortage and blah, blah, blah. And so I just struck this global burden, of the chronic disease. We hear a lot about diabetes and hypertension, but you're right. I don't think anyone really talks about this and how people are that. Where do you see us going, and what should we be doing to prepare our workforce a little bit better?
And I think starting with recognizing that it's a very prevalent disease that can really, it's like the number 3 cause of, death. So it really is an important disease. We need to, work on increasing awareness, patient level. As far as treatment, I don't even know how internist deals. It's just so many things to worry about, and you've got to worry about eyes and kidneys and everything. It's so much. Right? So I don't know what the right answer is. I would like to see every person with diabetes get a FIT4, which is basically ALT, AST, age, and platelet count calculation on your cell phone or on it's actually a dot race here. You can dot FIT4 and it comes up. It should be coming up back Alan, much to make that happen. So if we even did that and got that first step, first stratification, and the vast majority of people are going to be less than 1.3, and those people don't need any more care other than please treat the obesity and that cardiometabolic. And then the ones that have higher FIT4s, then those are the people that maybe should be referred. And so I think even if we just did that, that would be fantastic. Huge gain.
So I know we touched on it briefly last night, but what's your view of the introduction of these new medications like GLP-1 agonists? Because we haven't had much treatment for this, as you point out, but these drugs have revolutionized diabetes and obesity. And what's the impact going to be on your condition?
So it'll be huge. I would not be surprised if Novo Nordisk tries to get a label extension for this in their phase 2B trial. The response rate with our histologic end, which is NASH resolution, was actually upwards of 65-70%, which is the absolute highest we've seen. Unfortunately, though, there's no impact on fibrosis. So I think that it's going to be a very helpful treatment intervention because again, it reduces cardiometabolic risks, improves survival long-term, reduces kidney complications, all those important things. But from a fibrosis standpoint, if you have advanced fibrosis, I'm not convinced that it's going to be enough. But they're going to make a huge impact. And then tirzepatide and then retatrutide. I mean, amazing, right? The triple agonists are such, I think those are really likely to have more of an impact actually than semaglutide. Yeah.
I was struck by the process that you used, the Delphi process. In cardiology, we love our guidelines. We have guidelines for everything. And most of it is expert opinion and not really based on what we really want to base it on. How do you see taking this process that you went through? It sounds like a very vigorous process. Should we be thinking of using this process for all of our guidelines and how we approach things and go beyond just, what we know scientifically, but thinking of societal and stigma in everything that we put together as guidelines?
Yeah, I mean, I do think we need to be more holistic in our approach. I will say this was a very onerous process. So, I mean, I almost have PTSD when I hear the term Delphi. Okay, so it really, I think, is a way, especially if you have something that's controversial. If you have something that's not controversial, you don't need to do this. If you do, then it really forces a transparent and anonymous response and then discussion. And we really had some incredible discussions related to this during that process.
Jim.
You obviously have this fantastic experience now of moving this through the process. Can you talk a little bit about the barriers? Like, what were the biggest barriers for moving this type of initiative forward?
Yeah, it's 100% ego. That was really the biggest barrier. It was, bringing people back from, this is not about what you personally want. It's about what the collective has decided to do. That to me was the hardest thing to do. And even to this day, I mean, we've had, I think, 20 some letters to the editor. It's not even published properly yet. It's gonna be published in about a month. So it's, there's a lot. And it's like, well, I want it to be, nutritionists. I say, well, that's great. That's great. And we voted on that. And that was like 5% of the vote. So, that was to me the biggest barrier. And I think initially just convincing my society that it was an existential crisis, it actually was. And thankfully, not thankfully, but now with a little bit of time, we've seen that it was actually, it would have overcome everything and we would have not been, it would have been the United States, and the rest of the world. So I think this has joined us together, which I think is great.
About 20 or 30 years ago, maybe longer, I don't know, cardiology was really interested in this term metabolic syndrome, term which has probably been way overused and nobody knows what it means anymore. And so my question is, you mentioned the word metabolic again in some of the nomenclature you're using now. How do you think about this term? Should it be better defined? How does it fit in with what has been called metabolic syndrome? And how should we think of educating everybody about these terms?
Yeah, so there was a lot of debate, like, so what does it even mean, right, to say metabolic dysfunction? What does it even mean? But at the end of the day, when we asked, does that help you understand the disease? And I mean, I think like 80% were like, well, yeah. So even though you can't delineate exactly what it is, you know what that means. And I think that's why we end up supermajority selected. We really try to avoid the metabolic syndrome. I try to never say metabolic syndrome because I know that it's a heated, debate in endocrinology and cardiology. I just talk about cardiometabolic risk factors. I don't talk about metabolic syndrome at all, actually. I tried that. Anyway, I was quoting a paper there, so that wasn't mine.
Please.
Yeah.
Excellent talk. From a very different perspective from the eye world, but I'm just wondering, why do you see an increase? Is it diet driven? Why we see increase in this kind of this process? And should we include in this multidisciplinary integrative approach our patients instead of nutritionists?
Yeah, so I really think nutritionists or dietitians are probably the most important piece of the puzzle. Why? Because we all know how successful people are when you say, you need to lose weight and then I'll see you in a year. And of course, nobody loses weight because everybody knows what they're supposed to do, but nobody does it because it's really hard, right? It requires a fundamental change in how you live. So I think a dietitian is critical for that because it provides points of contact. And there are data that the more points of contact you have, the more likely you are to be successful. And so I think that you have to support people in that. So I personally believe you really have to. And one of the goals of the HepVita project is actually has embedded in it a link to a company called Fay Nutrition, and they have thousands of nutritionists. And so a patient who normally doesn't get coverage for that, normally, as you know, it's very hard to get coverage. I think they pay like $40 a month to Fay, and they get pretty much access to nutrition guidance. So that I think is really important. We do not have enough dietitians. And so that's what part of what we were trying to do with that.
Well, at this point, I'd like to reintroduce our board and ask them for a few comments. Dr. Jordan Cohen, who's President Emeritus of the Association of American Medical Colleges for 12 years. Dr. Arthur Rubenstein, who was Chief of the Chairman of Medicine here for 81 through 97, and then Dean at Mount Sinai Medicine in New York, and then University of Pennsylvania as Executive Vice President of the Universal Health Systems and Dean of the Perelman School of Medicine. Dr. Laura Roberts, who's the Chair of the Department of Psychiatry and Behavioral Science at Stanford for the past 12 years or so, is also a former medical student and McLean student fellow here as well. Want to welcome our board members here and open it up to our board for some comments on both the lecture and our board meeting today. So I'll open it up to the three of you.
Already indicated how much re-educated me about liver disease, which I thought I knew about from my long ago training, but it's very instructive to see how to deal with this so fast, much more responsive to the realities that we're dealing with. So I congratulate you for that. I think our board meeting today was spectacular. I think the accomplishments of the Bucksbaum Institute have been just remarkable. Relatively short time, 11 years, that the Institute has existed, has produced not only incredible role models and scholars, but also has really put the institution, I think, in a position of real leadership in terms of an area of medicine that is much more needed now than it was in terms of what's happening in the world, the kinds of attitudes and qualities and dimensions that are being worked on here are going to, I think, be exceedingly important. So I couldn't be happier or prouder associated with this incident. It's been a remarkable experience.
Yeah, no, I kind of said what I wanted to say to you, Mary. I think it was really a great talk. And I guess I would emphasize that it's so remarkable what the Bucksbaum Institute is doing. And I would turn to all of you. There's so many places you could be, and you choose to be here in this conversation. And I think that really reflects the values of the university, but also your values. And so I wanted to acknowledge that. And Mark's incredible work in leading this at the McLean Center all these years. I think you did a great job of demonstrating how consequential this is, kind of a neglected problem, and kind of illustrated how we can kind of bump up and make people anxious that it hasn't been attended to sufficiently. I also think that you, through just all of the ways that you talked about it, addressing stigma, the misunderstandings, I think your compassion came through in a kind of a sciencey talk, that compassion and the need to address patients where they are and to address the cultural issues also came through really. I thought the way that you thought about scientific work is really benefiting patients and illustrated kind of the point, I don't know where it was about billing. You kind of took an idea all the way through the science, through all of the implications, and then how you might actually implement it, getting FDA approval and support. Clearly, we've got some CMS work to do, but that art is kind of remarkable and really appreciate that. And I guess I would reemphasize the point I made earlier about cancer. You know, the New York Times did a really piece about how, you know, people get the cancer diagnosis, no matter whether it's a slow growing, really affecting maybe quality of life. Actually, the treatment is probably worse for their quality of life than the cancer itself. To, you know, people who need to make peace with their lives and in a transition, a different journey in their life. Cancer covers all of that. And so I think by demonstrating this Delphi process for everyone, you kind of showed us all a path forward out of things that seem a little bit stuck. So I thought that was really fantastic. And I do hope that you'll continue to be a wonderful role model, bringing together all of these five missions of the science and the clinical and the education and the community, and then the leadership and policy change. Because that's how we go from the united power to it, like a transformational kind of way of changing things throughout the world that we're entrusted with in academic medicine, and sometimes isn't easy to explain to people, but you illustrated so nicely. Arthur, you're up. You're in.
Thank you. Hard to follow you, Laura. So I guess the thought I had today and last night, and Mary will probably forgive me for repeating it, or she won't, and that will be bad news. Culture and ethos in an institution is very underestimated. People think money is very important, which it is. And facilities, very important. Look at these beautiful buildings and so on. But culture and a feeling of working for a good cause, probably in my view, is bigger than all these things. And it's what leads to recruitment and retention of faculty, attraction of great students, nurses and allied health people, and makes the place worthwhile to work in. And so Mary told me last night she was at Northwestern for 20 years maybe, and she came back here and felt quite at home. Of course, she grew up here, so that's another thing. But that's pretty instructive because Northwestern has plenty of money and facilities, but if you feel better working here, that's really, really important. And I would say the Bucksbaum Institute and all that it's done has created a culture in this institution or added to other things, but it's very important in terms of the beauty of working in a place that's worthwhile. And so I would say, Kay, you couldn't have done much better than that because you transformed a whole institution from being good to being great. And that's pretty important. And if you can attract people like Mary and others who would rather work here than elsewhere, that tells you about the beauty of the place. So congratulations to you and Mark. Enjoy working here. And so I've been here for 30 years of my life, and then Mount Sinai and Penn, and they're all great institutions for sure. But there is something unique about this place that you should all treasure and enjoy it. I think the Bucksbaum Institute has added to that in a very major way. Thank you.
I want to thank Dr. Ranella for a wonderful talk, stimulating discussion. All of our faculty and friends and colleagues who came here to the meeting here in the other room on Zoom, thank you for joining us. To our distinguished board, thank you for coming from out of town and joining us today. This is just the beginning of bigger and greater things for the Bucksbaum Institute. So we're very thankful for your support. We're at the end of our hour. Look forward to you at future Bucksbaum meetings. Thank you, everybody.
Thank you.